Well, good morning, everybody. Welcome to Grand Rounds today. This is taking place on Mi'kma'ki, which is the traditional unceded territory of the Mi'kmaq people. And we are all treaty people, and our department's committed to the truth and reconciliation recommendations as they apply to healthcare and other areas that affect children and youth and healthcare workers. It's my pleasure today to introduce Emma Bartlett. Dr. Bartlett is one of our third-year pediatric residents and also one of our co-chief residents, and is doing a fantastic job along with Tess in that. Emma is from the East Coast, and she completed her training here at DAL, including a brief stint at the DAL Theater Department prior to medical school. So she knows how to perform and present. So this is Emma, no pressure. Emma has a strong interest in adolescent health and vulnerable populations, and she's very excited to be heading to the West Coast in July for an adolescent medicine fellowship in British Columbia. And I'm hoping someday we will bring Emma back in that capacity to the East Coast again. Emma is going to talk about adolescent pregnancy and some of the implications around that. So Emma, I'm going to turn the floor over to you. Welcome.
Excellent. Thank you so much. I'll just get my screen up here. Just bear with me for one moment. And I'll move this over. Make sure that everybody can see that there.
Looks great, Emma.
Excellent. So as Dr. Lang mentioned, my presentation today is on adolescent pregnancy and parenthood and what our role is as pediatricians. And so, make sure that I can move through here. There we go. So I know Dr. Lang did do a land acknowledgement as well. I just wanted to acknowledge that the land we're on is Mi'kma'ki, the unceded ancestral territory of the Mi'kmaq people, and acknowledge them as the past, present, and future caretakers of this land. I'm very grateful to work and learn on this land. And I think particularly with the subject matter of today's presentation and the disproportionate impact on Indigenous adolescents and the risk that we fall into with perpetuating intergenerational trauma and how we care for these patients, I really think it's important to keep that cultural context at the forefront of our minds as we go through this presentation. So the objectives for today's presentation is to understand the healthcare needs of adolescents in pregnancy, postpartum, and parenthood, to identify key members of our healthcare team to support these adolescents, describe the role of the pediatrician in that support, and to examine our local landscape of adolescent pregnancy care, including resources, models of care, and vulnerable populations. And these are very broad objectives. And as this presentation took shape, I'm realizing more and more the role that we have as pediatricians in being advocates for these youth and for the children of these youth. And when I mention the local landscape, there's also a significant role of our hospital and medical community in ensuring that these patients don't fall through the cracks. So I have no financial disclosures or conflicts of interest for this presentation. And I'm putting up this case initially because this was my version 1 of the case for this presentation. And as somebody who's interested in working with adolescents in my practice, I initially had thought that this would be a typical teen parent. We have a few things that we flagged on our heads interview. Her name's Stephanie. She has ADHD, anxiety, cannabis use. So a few things that we might follow already in the pediatrics clinic. And I had originally planned this presentation to sort of direct to resources. How can we in our clinic support these patients? And when I look back on this version, it feels incredibly naive as a pediatrics resident to have this as my impression of adolescent pregnancy, which is why I think it's so important to introduce you to a more representative patient. And so this is our real life version. And I will say this is a lot of information on the slide, and this isn't even the full story. I really had to pare this back for the presentation. But this is Stephanie. She is 14 years old. She had a confirmed pregnancy and her local emerged 2 weeks ago. Her family doctor sent a referral to obstetrics for prenatal care. She has irregular periods and does not know when her last menstrual period was. She has not yet heard about the follow-up. She was seen urgently only because you happen to have a drop-in clinic at the group home she attends, and she was seen for syncope and vomiting. But otherwise, she may have not presented to care if there wasn't this drop-in option. She has no prenatal care, no medications, and is on no prenatal vitamins. She says that she's very happy about having this baby. She smokes 1 gram of cannabis daily, vapes nicotine, mostly for severe anxiety, but she's very motivated to cut back during the pregnancy and has been. She's not attending school. She's from a single parent household. At times, though, she's unhoused and couch surfing and has been in care on and off due to her housing situation. And I really want to highlight the complexity and risk level that I'm hoping you all can see in a case like this, which is very realistic representation of some of the youth that are out there in our community. And this is the really hard truth of what happens to some of these youth and all the different points in which they may fall through the cracks of our system. So you book your follow-up in 2 weeks for her. You had set her up with a referral to psychiatry. You provided nutritional counseling at your last appointment, started her on diclexin. You had called obstetrics to make sure that her consult was received, and you refer her for a dating ultrasound. However, when you see her in 2 weeks, you see on Meditech as you're scrolling through that she was marked as a no-show for a dating ultrasound that had been scheduled that week. When you talk to her, she never knew about the appointment. And because she's housed in a group home, her social worker also wasn't notified of this. So you call the IWK and you learn that the policy that we have for notification when it comes to pregnancy-related matters is that they have to talk to the pregnant person themselves, which I completely understand the reasons for that with confidentiality, but also recognizing that the common sense of it is that it's a detriment to youth in care and for people who are unhoused. So you learn of this, and despite your instructions on the requisition to call the group home directly, they were unable to do that. So then you call radiology to try to have her seen, because again, you don't know when this youth is going to present back to your clinic. And they say they have a small window that afternoon if you can get this patient to the IWK. You arrange the transport, again, amongst your busy clinic, and on arrival, the door screeners don't let her in without an appointment letter. And so the patient calls you confused and alone at the hospital, having met so many roadblocks and barriers. Again, if you want to talk about a Swiss cheese model, there are many holes in this situation where this patient could have been completely lost to follow up and not receive the proper care, because at this point, you still don't know how far along she is. And so we'll take a step back and look at our epidemiology of adolescent pregnancy in Canada and in the Maritimes. So the rate in Canada is 4.9 per 1,000 births in patients aged 15 to 19. In Nova Scotia, the rate is a little bit higher, it's at 5.8, and same again higher in New Brunswick. PEI is a little bit below our national rates. And again, that may not seem like a significant amount of patients, but that equates when you look at the birth rate in those years. It equates to about 41 patients here in Nova Scotia. And that's not only in the prenatal period, but then also these are families who are going to have young babies and children who will need the postpartum care and follow-up as well. And so as I was starting to look into resources for this presentation, I was really shocked at the lack of information and literature, specifically from our pediatrics guidelines and in general about how to care for adolescents who are pregnant. And so much of our pediatric training and guidelines are surrounding prevention of pregnancies. So that's why I have this infographic of all the things that I was seeing as I was looking this up. Lots about contraception, counseling, prevention, but little about what we actually do when we have these adolescents in front of us. And although it's a very important part of our practice to be screening for sexual health concerns and providing contraception, I deliberately did not put any of that in this presentation because I really wanted to focus on what we do when we have an adolescent who's pregnant right in front of us. So I don't have any talks about prevention, contraception, or even options counseling in this presentation. But seeing all of this information, it really made me reflect on the fact that it's our business to be doing the counseling and preventing pregnancy. But how is it that that care is no longer mirrored necessarily once the adolescent is pregnant? And the fact in this quote, which is from a clinic in Ottawa, they did a pilot study on an adolescent clinic for pregnant adolescents. And I do find it very interesting when it comes to the research aspect as well. And so why this population isn't studied as rigorously as some other perinatal issues. And so this brings us to what the actual healthcare needs are of these patients. And as we move through the presentation, I really invite you to acknowledge any biases that may come up or any knee-jerk reactions. So I recognize our pediatric system is already very strained, but if you have the thought through this, that why would this patient be seen in peds, or that their social complexity isn't necessarily a chief complaint, I invite you to challenge those thoughts, as it really made me consider, as I went through this, why we see some risk factors as more valid than potentially other risk factors in our referral system. And so I know this is a very big infographic, and I hope you can see it all on your screens. But this is the complete care of youth patients and their children. So this is an infographic created at Sick Kids by Their Young Families program. And it was designed by both youth patients, so adolescents who are pregnant in their clinic, as well as clinicians who work there. And it really addresses sort of all of the domains of healthcare for these youth. And we'll break this down as we go through the presentation, as I use this as a bit of a framework and a guide. But I also want us to be thinking about the developmental stage of these patients. And so we think about developmental stage in all of our youth appointments, but thinking about that in the context of them as parents, as they're very different than our adult patients that we see on the women's side, yet they're often in a system that's designed for adults. So in early adolescence, we have our onset of puberty and very concrete thinking when they're working through problems. And as they move into middle adolescence, that interest in relationships, both romantic and sexual relationships, starts to evolve, and that desire for independence. But in amongst that, there's still a very developing frontal lobe. So that complex decision-making, impulse control, ability to consider multiple options and the consequences of those actions is still very much developing. And then in late adolescence, we have more of the personal values and individuality, but again, improving, but not quite fully developed frontal lobe function. And so for much of the medical guidance around sort of the management of these patients from a medical lens, I use the SOGC guidelines on adolescent pregnancy, as well as this framework. So this is the maternal health section from that Toronto Sick Kids framework. And so the biggest thing, I won't go through all of the recommendations on the SOGC guidelines, as that's not necessarily the full focus of today's presentation. I do link it at the end in my resources. We have a number of resource slides, and I would recommend that as sort of the general guideline for the medical care of these patients. The thing that I really want to highlight and what struck me in that guideline is that they identify adolescent pregnancies as high-risk pregnancies, predominantly for a lot of the social risk factors that are present in this population. And so they recommend that these patients should be in programs that can accommodate their unique risks and concerns. We know that adolescents have significantly lower attendance of prenatal classes and first trimester visits, and they have a lack of knowledge on the importance of that prenatal care and the potential consequences. There's many reasons why youth may not present, as you saw with our initial case example. There's lots of barriers, both financial, transportation, as well as a lot of concerns about lack of judgment from healthcare providers, lack of privacy in the care because this is a brand new healthcare provider for them, as well as the fear of potential apprehension of the baby. So there's many barriers that may present when they are trying to present to care. And so I'll go through some of these risks a bit more in depth, but in terms of the maternal risk, there's higher rates of mental health disorders, there's higher rates of repeat pregnancy, substance use, STIs, and intimate partner violence. And we know that these adolescents are less likely to have attainment of education, lower income, more likely to have difficulties with self-esteem and lack of social support. And so again, when these risk factors are identified by the sheer nature of this patient being an adolescent who's pregnant, there's no reflex to refer them necessarily to services or pathways that they're connected to. So often it's the tireless work of individual clinicians who are trying to patch together multidisciplinary care in a very siloed system. So when we think even about the documentation and communication alone, it's very hard for us within the walls of the IWK or within the walls of a hospital to necessarily know what's happening in a community practice, like a community family medicine or obstetrics practice. So again, it's often a lot of extra work in terms of trying to patch that together. And then there's also the risks to the baby. So these are the fetal risks of increased risk for premature birth, low birth weight, IUGR, perinatal mortality, NICU admissions, and congenital anomalies, particularly anomalies such as spina bifida, microcephaly, GI anomalies like gastroschisis and omphalocele, and MSK related anomalies such as cleft lip and cleft palate. And these are only the immediate fetal risks. So as we know, as these children grow and develop, there are also further risks, both with the initial fetal risk factors, as well as the increased risk of substance use in adolescent pregnancy and risk of decreased prenatal care. So all of those factors put these infants and eventually children at high risk. We'll continue to go through here. So we break down these risk factors in terms of what are the areas of care that we should be looking at when we're providing care to these patients. And so when it comes to anemia, this is very common in adolescents, prevalence from 50 to 66%, and an increased relative risk compared to their adult counterparts. And so this is usually attributed to inadequate nutrition and inadequate replacement. There's also smoking status can be an important risk factor for anemia, as well as our risk of low birth weight. In terms of STIs, they can be associated with preterm delivery, postpartum infections. Adolescents do have a high risk of STIs, which leads a higher risk of PPROM and preterm birth. There's also vertical transmission risk of chlamydia. In terms of the recurrence rates, they can be quite high as well. So even on third trimester routine screening, an infection rate of 22% in adolescent pregnancies. They also mentioned that bacterial vaginosis has been associated with adverse outcomes. They do note, though, that some of our routine screenings, so gestational diabetes and hypertension, may not hold the same risk for adults as it does for adults. So we would just do the same routine screening as we would for any adult pregnancy. And when we go through into exactly what that means for our care, for the risk of prematurity, it's recommended to not only have the dating scan, but frequent visits and routine screening throughout the pregnancy for substance use and intimate partner violence. For anemia, to involve dietitian early screening for this in blood work and iron supplementations. In terms of the risk of low birth weight, having frequent visits, a 32-week ultrasound for growth and nutritional support. There's a lot of programs, and I will link to some resources at the end when it comes to nutrition. So there is a Canadian funding program called the Canadian Perinatal Nutrition Program that funds a lot of our family resource centers for things like food donations, vitamins, and prenatal nutrition programs. So those are really excellent resources for that aspect. And then for STI screening, making sure that this is routine and ongoing throughout the pregnancy, as again, this is a high risk and can lead to potential fetal risks as well. And then we go to the psychosocial risks, which are quite prevalent for this population. So starting with just our basic needs of financial needs, housing, education, as often these youth are not attending school when they're pregnant, and even things that you may not think about in the healthcare system, but clothing like maternity clothing, which if they don't have that may limit them in terms of what they're doing for their own health and education, if they don't feel that they can leave the home because they don't have proper maternity clothing. In terms of smoking and vaping and substance use, these are all much higher rates in adolescents who are pregnant compared to adults. The rates of intimate partner violence in pregnant adolescents is about 26 to 30%, which is again much higher than the adult counterparts. We all know that there is significant risk in adolescents in general at baseline for different mental health conditions, but the rate during pregnancy is up to double the amount of the baseline adolescent population. And again, untreated maternal depression can be associated with adverse maternal, neonatal, and childhood outcomes, and can lead to some difficulties with attachment and behavior as those infants grow and develop. And in terms of our access to care, again, I really hope that that case at the beginning illustrated some of our significant barriers for these youth. And in that case, that was with someone who had a family doctor who already had a referral into OBS and had a pediatrician who was advocating for them throughout this pregnancy, and still they ran into barriers in our system. So adolescent pregnancy should be in programs that can accommodate their unique risks, as these are not adult patients, but are often in an adult system. And so in terms of how we can address some of these issues, for the basic needs, trying to involve social work as early as we can and connect them to local resources. There can be shelters, food banks, donations, and different school options. But again, we need to help these youth navigate those options. For smoking and vaping, there are smoking cessation programs, and a harm reduction approach is always recommended. For counseling around substance use and alcohol use, we do have our concurrent disorders clinic. So Dr. Celine Etches does see many of these patients. As well as for adolescent intensive services, these youth, because they are pregnant and because they're using substances, they would be priority for enrollment in the AIS program. When it comes to intimate partner violence, we really need to be using validated tools and recognizing this in our populations, and I'll go over some of those in a moment. And as I mentioned, consulting psychiatry for the mental health conditions. And of note too, these patients would fall under the if they're 18 years or less, they would fall under the category of our consult liaison here in the IWK. So thinking about that when there is the option to consult psychiatry while they're inpatients as well. And I put a note in here about the grief counseling, because as we know, with the risk of perinatal mortality, there can be a risk for these patients that they may leave the hospital without a baby. And so really recognizing that, as they don't have the developmental stage to necessarily process such a devastating event. And so making sure that they're well connected if that's the outcome of their pregnancy. And for access to care, as I've mentioned many times, having an adolescent-focused multidisciplinary care approach, and thinking about that when we think about transportation and even scheduling, if we're trying to promote for these adolescents to be in school, but then are making a lot of their appointments in times when it's very inconvenient for them to be able to continue to do that, just thinking about that and how we're scheduling. One other note as well, under the mental health conditions as well, there is also a 0 to 5 attachment clinic for infant mental health, and that's another mental health resource that can be incorporated into our care. And just a small note here on the intimate partner violence, which I have the QR code here is for multiple screening tools that are commonly used in pregnancy. And so, as I mentioned, in pregnant adolescents, the risk is 26 to 31%. And then this is our risk just at baseline as well, noticing that the lighter blue category is women age 15 to 19. And so this is outside of pregnancy. This is just in general, the rates of intimate partner violence in relationships. So thinking about this as we're screening adolescents, but also recognizing that there's a risk of becoming very paternalistic when we have these conversations. So we really need to take a motivational interviewing approach when we're talking about intimate partner violence, and sort of working with the adolescents and meeting them where they are, as we don't want to ruin that therapeutic relationship moving forward. And then just a slide on the statistics when it comes to sexual exploitation as well, as youth trafficking is a significant issue in our province. I will say these numbers are likely grossly underrepresenting the actual numbers of human trafficking in our country and in our province. But it really was alarming seeing that the rate in Nova Scotia, so 5.3 per 100,000, is over double of the next highest provinces, which is Ontario and the Yukon Territory. So, and the overall baseline rate for Canada is 1.4 per 100,000. So recognizing that our province specifically is at a significantly higher risk for our youth, again, not only pregnant youth, but youth in general, and that about 25% of victims are age 17 or less. And then I'm just going to see in the chat, oh, there we go. QR code, yes. I think inspired by Alexis's grand rounds. So the intrapartum and postpartum considerations for these youth, our studies suggest that the standard care often misses a lot of these psychosocial vulnerabilities, including many of the postpartum issues, such as contraception and school return. And so this is the area where these youth can often fall through the cracks, as once the baby is delivered, they no longer have that obstetrical follow-up, and really who is there to be caring for these adolescents afterwards, as well as the children of these adolescents. And so adolescent mothers are at significant risk for increased pregnancy, about 25% becoming pregnant within the 2 years of delivery. So discussing family planning if they are wanting to become pregnant or if they are not, discussing contraceptive methods, particularly more longer acting contraceptive methods such as subdermal implants or IUDs. And there can be compassionate contraceptive assistance if funding is a concern for this. And so, oh, 1 second, there we go. So in terms of what we do to address these issues, so in hospital support, using the resources of our birth unit nurses and clinical nurse specialists, they often can offer tours and support prior to delivery. But again, we need to know about this and know to ask for this. For in hospital, there is a volunteer doula program for low-income families through the Shabukto Family Center here in the HRM, and they give priority to parents who are less than 25 years old. In hospital is not always a welcoming place, though, for these youth, and there's often fear of potential apprehension of the baby. And so really being mindful of potential DCS involvement. Although we no longer have birth alerts, there's still many risks of bias and racism and influencing the decision of taking a child into care. So although DCS can be supportive in a role of some of their programming, like the Family Connections program, where a coordinator would work with the expectant families and focus on engagement and outreach, just knowing that there is this hesitation with having them involved and the significant risk of trauma if these babies are taken into care in the hospital. And so at the IWK, we do have a policy on taking a child into care, which I think is good to be aware of if that's ever a situation that you're in. And also knowing that DCS does state that they make every effort to resolve issues. So really being an advocate to make sure that that's happening and that these families are given the support prior to those babies potentially being taken into care. And in terms of parent education, thinking about our models of how we provide this education, as again, it's very geared towards adults, and thinking of the developmental stage for these patients, if they can comprehend the amount of parent education that we're giving, and we may need to tailor how we're providing that. In terms of postpartum follow-up, as I mentioned, discussing the family planning, and also things like school return and things that are going to be important for this adolescent to be able to thrive and to really reach their potential as a parent. So thinking about who is actually going to be following and supporting this family. As I mentioned, for early attachment, we do have the consult of the 0 to 5 special care clinic in psychiatry, as well as Dr. Carey, who runs that clinic, can do neonatal behavioral observation on the unit if you have concerns in hospital for attachment. And really thinking about the family dynamic. So there may be grandparents or other family members involved who are going through their own emotional process. So really keeping the focus on this family, the youth and their child, and who we're trying to support here. And then, as I mentioned, there's many community services, and I will go through these at the end. Just a note too, when it comes to the family involvement, with our programs, we do try to support both parents. And so if there is a father or another partner involved, but also knowing that decisions about who to include in the care and whether we're including the other partner is often a complex decision and can require a lot of special consideration of the risks and benefits of involving those parties. And so what are the healthcare needs of the children of these adolescents? So in terms of the risks, we mentioned the fetal risks, but also as these children start to grow up, they continue to have health risks into childhood and adolescence. So in the early years, we have growth and development issues, cognitive speech and language delays, the risk of accidental injury and neglect, and attachment concerns. And in the later years, these children are more likely than their peers to have lower educational attainment, to grow up in a single parent household, to be involved in alcohol and substance use, and to become adolescent parents themselves. And so this cycle just repeats itself. When you add in the layers of intergenerational trauma and adverse childhood experiences, it's really not a surprise that these kids have not been given a fair start from the beginning. That again, we can't place the blame on these adolescent parents, as without adequate support, they really can't reach their full parenting potential. And it also makes me think about really where we set that benchmark for adolescent parents versus our general parent population. As many adolescents can excel in parenting, often that's with supportive social networks, positive parenting environment, and limited adversity, which we know a lot of these youth are facing significant adversity in their lives. But just knowing that they do have that potential if we provide them the correct supports. And so in that assessment of the child of an adolescent parent, these are the main domains that are recommended when it comes to screening and assessing the needs. So this comes from the CPS articles addressing the needs of adolescent parents, as well as the positive parenting article. So screening includes regular things that we screen for all the time: growth, development, nutrition, attachment, feeding, sleep, immunizations, but also a similar mirrored screening for ACEs at home. So what the home environment is like, neglect, abuse, exposure to violence, as well as checking in on the parental mental health. Providing that education, as I mentioned, that's provided in a way that's easy for that adolescent at their developmental stage to understand, that strengths-based models communication when you're in your appointment, and connecting them to local parenting programs and support groups. And really underlying all of this is the support that we're providing to parents to address their basic needs as well. So not forgetting about the financial, housing, food security issues that are common, again, not only in adolescent pregnancies, but across the board in many of our pediatric patients. And so I mentioned a lot of risk factors and a lot of healthcare needs. So how do we actually go about addressing all of these needs in practice? And so from the SOGC guidelines, they mentioned that having an adolescent-centered, multidisciplinary, comprehensive care is the gold standard for managing these issues, and that successful models have been implemented in hospitals, schools, clinics, and community facilities. So sort of that one place at one time model. The American Academy of Pediatrics also supports this medical home model, and also mentioned that a lot of these components can be transferable to community-based practice. We also have the Canadian Pediatric Society that mentions having integrated medical home elements for patient-centered care, and that the people who are providing this care understand adolescent development and can facilitate those positive health outcomes for the mother and the child. And I'd really love to hear if any of this is occurring in our pediatrics clinics outside of the IWK as well, because my perspective as a resident based here in Halifax, mostly based at the IWK, is I've really only heard of individual clinicians who have an interest in this care and are noticing these gaps in our current system, but I'm not seeing sort of any coordination of care. So I'd love to hear if there's any of our community practitioners who have had similar models to this or who are practicing this type of care as part of their pediatrics practice already. And there we go. And then lastly, the Healthy Babies, the Healthy Babies, Healthy Families, which is the Nova Scotia Health and IWK mandate, stating that although they don't mention adolescent pregnancy specifically, they do say that their guidelines are of particular importance with families with complex needs, which includes teen pregnancies in their guidelines. But saying that these services should be developed collaboratively and having identified and addressing gaps that provide seamless care. So those gaps in the postpartum follow-up, those gaps in communication are, again, really not adhering to this standard. And it makes me wonder what we can be doing here at the IWK to better meet these guidelines that we set out. And yes, I'm noticing the question about resources. So I have a bunch of slides at the end of my presentation of resources, and I'm happy to send those out to anybody. In terms of the evidence here, I just included 2 studies. These are highlighted in the SOGC guidelines, but they have many other studies that are reinforcing similar evidence. So the 2 studies that we focus on in the guidelines is that in a cohort study in Australia, they had a specialized adolescent clinic, and they really had to focus on STI screening and treatment. And they noticed a significant reduction in preterm birth compared to those adolescents who had general antenatal care, as well as in a cohort study in Canada, where they had a multidisciplinary adolescent community outreach program. They saw a significant reduction in low birth weight babies and preterm birth, and they had a big focus on nutritional requirements and maternal weight gain. So again, these are just 2 studies, but the SOGC guidelines does mention and like multiple evidence of this happening. Again, not many clinics in Canada that are providing this care. And as I've mentioned earlier, there's not a lot of rigorous research that's going into some of these social determinants, which would be excellent to see, as I know we have a lot of rigorous research on other perinatal outcomes. And so what models are being used? So how do we take these recommendations, and what does that look like in the logistics of having a team-based approach and having a multidisciplinary care clinic like this? So the first example is the Sick Kids Young Families program. So that is a healthcare service for adolescent mothers and their children. As I mentioned, that's the team that functions there. So pediatricians, nurse practitioner, registered nurse, public health nurse, social workers, and a psychiatrist. And referrals can be made at any stage in pregnancy or after delivery. And this can be made by healthcare providers or the adolescents themselves. So it's any parenting woman under the age of 19 who would benefit from their support with parenting or complex health needs or psychosocial concerns around pregnancy. And so this is their list of all of the complex services that they provide. So as I said, really complete sort of wraparound care of these families. And you'll notice that this list doesn't include prenatal care specifically, but there is a parallel obstetrics clinic. It's a young mom's clinic that's often obstetrics, social work, and nutrition. And although they don't work in the same building or necessarily out of the same clinic space, there is communication between those 2 programs, and they often share many of the same patients. And so the other clinic that I wanted to mention is the St. Mary's Clinic in Ottawa, so St. Mary's Home. This was already established as a hub for particularly adolescents who were not only pregnant, but also unhoused adolescents, as a way for them to have a lot of services in one place. They have a well baby drop-in clinic, dental services, an obstetrics clinic out of this home, as well as the school board was involved. So they had a satellite high school as well as a daycare. So they had lots of services already here, particularly also a lot of nutrition support. So they had breakfast and lunch provided, as well as options for nutritional classes, and a lot of peer support because it was a lot of other youth who were pregnant as well. And so when they saw this as a hub for a lot of the obstetrics care, they did an adolescent outreach pilot clinic, which was out of CHEO, so out of the Children's Hospital of Eastern Ontario. And so again, these were all of the services that they providing that complete care for the adolescents. And an emphasis again is on the youth focus that they had. And so it can be really difficult at this age to see those long-term benefits of services. So even if we provide it to them on a silver platter, say, here are all of the things that will benefit you and your baby, we still need to be considering how we're presenting that information and making this youth friendly. So instead of just having didactic information, similar to my presentation today on all of the risks or information on milestones or the importance of attachment, they would do activities that engage the youth, like having a photo day with all of their babies and putting all of their milestones into a baby book, so that it really was targeted at what the adolescent's developmental stage was. And they did do a study as well based on this pilot clinic. The demographics were quite skewed because many of these youth were disadvantaged in terms of income and education, but 61% had no primary care provider. And there was a clear need for an adolescent clinic on top of the obstetrical care that they were providing, as the obstetrical care had excellent success when it came to prenatal care and neonatal outcomes. But when they started working with these adolescents, specifically for a subset of the patients, they noticed significant need for additional services for mostly those psychosocial concerns and the postpartum care. So again, this was a one-stop shopping model of service delivery that allows for that multidisciplinary approach. So what are we doing in our local community? So what are our services that are being provided? So in our local context, and I apologize, I know that this is mostly HRM focused in terms of what we have, but there are some of this can be still applied or applicable to our community practices as well. So at the IWK, we have our obstetrician-led clinics. These are either self-refer, referred by a physician or NP. They're multidisciplinary, so there's the option to see a dietitian, social worker, or physiotherapist, but again, it's not an automatic for all the patients, and this is an adult-based clinic. There's also subspecialty clinics through obstetrics. So there's a substance use and pregnancy clinic, as well as Dr. Van Eyck has an interest in adolescent care. So if referrals come through, they're often sort of sent over to her, and then she'll see in her general obstetrics clinic. And then there's the family medicine-led clinics. So again, these are very community dependent, and across the Maritimes, very community dependent in terms of the involvement of family physicians in the obstetrical care. Here in the HRM, they're sometimes run in the community, sometimes run out of the IWK. And then for the postpartum follow-up, we have our unattached newborn programs. But I really want to highlight that these programs, although they're very important from a public health perspective to ensure that these neonates are getting kind of the minimum level of care, they aren't taking the adolescent on as a patient. So they aren't addressing a lot of those complex psychosocial needs, and they're squeezing in these patients into already very strained primary care clinics. So although it's helpful to have that for the newborns, I really don't think that addresses all of our concerns that we have for these youth. And a note that there are midwifery clinics, however, they're not often involved with adolescent cases. They may have some adolescents on their list, but given the high risk nature, often family medicine or obstetrics is involved. And as I've mentioned, there's no coordinated process for getting psychiatry or pediatrics involved. And so we have lots of options with psychiatry. We have consult liaison who could do in-hospital consults. We have our community mental health as an outpatient, the concurrent disorders clinic that Dr. Etches runs for substance use and mental illness, again, and she sees many pregnant patients, as well as the age 0 to 5 early intervention clinic. In pediatrics, we're often involved when these patients make their way through the NICU program, either if they qualify for perinatal follow-up, or often the neonatologist will think that maybe this patient requires some more pediatrics follow-up. But otherwise, there's no coordinated process just based on the risk factor of being an adolescent pregnancy for these babies or their parents to be referred to pediatrics. Also, again, a note of with our referral system, the IWK often sends letters, which doesn't really work if patients are either in a group home situation or don't have a stable address. And often if we're confirming with telephone calls, these might be during school hours, making the assumption that these youth have a phone. So it puts a lot of adult responsibility on these youth patients. I will say there's not an easy solution to this, but again, it's often required a lot of detective work on those individual clinicians who are providing care. And then I'm going to just briefly, for the sake of time, go over a couple of quick local research articles. So this was done here in Nova Scotia, just trying to look at what the experiences of postnatal care. And really what I want to highlight with this is the variability. So all of these patients were adult patients. And as you can see, there's significant variability in terms of when they had postpartum follow-ups. Although many were interested in terms of having although many were satisfied with the care that they received, about 72%, there were many situations associated where there was unsatisfactory care. So challenges with accessing care, gaps in follow-up visits, and unsatisfactory assessments of the maternal needs. And so this quote here, which again, these are adult patients, but it just breaks my heart to think of this applied in our adolescent population, where they say, I feel like when you're pregnant, you get an appointment every month or week. And then after a baby, you're kind of forgotten about and no one cares as much. And so again, thinking about how a lot of the focus is placed on the baby and we're not thinking about maybe those maternal risk factors postpartum. And the other study here was of the outcomes of adolescent pregnancy. And really for this study, it really shows similar statistics as the SOGC guideline studies, which are more like larger based national studies. And so these were 11% of the pregnancies or adolescent pregnancies. They had higher rates of smoking, substance use, lower attendance of the prenatal classes, and inadequate weight gain. And some of their biggest risk factors that they saw was the risk of SGA infants. Some of the outcomes that were noted as risks in the national studies, such as NICU admissions, were not as significant in this population. But again, this was a smaller study compared to those much larger national or international studies. And so really the conclusion of their study is that it reinforces the value of a targeted multidisciplinary approach given the socioeconomic characteristics of these patients. Which brings me to the biggest question of this presentation, which is what is our role as a pediatrician, given the fact that we know all of these risk factors for these patients, and the fact that both of these, the adolescent parent and the child of the adolescent parent, both fall into the category of pediatric patients. And so, as I mentioned at the beginning, our role is really deeply rooted in advocacy and recognizing that we need to invest in these kids who are already starting 10 steps behind. So the role of preventative medicine, as we know that these are risk factors for further issues in childhood and adolescence. And so we really should be treating these social risk factors as we would any other perinatal risk factor. So coming back to our framework here, and we'll work through these different domains, but really I want to highlight that a lot of these domains are well within the scope of pediatrics. And so in terms of infant and child health, I think this is the most obvious one. So a lot of these areas of nutrition, growth, sleep, parenting, developmental screening, early intervention, these are things that we commonly address in our clinic. And knowing the high risks of these children and the crucial time of infancy for development, the role of preventative medicine and early intervention may protect these children from the impact of further adverse childhood experiences. And really, I think this falls under the social pediatrics lens as well. So thinking of that child and their health in the context of the environment that they're currently in. And then looking at the maternal health, which initially when I saw this aspect of the total care, I kind of thought maybe this is more obstetrics related. How do we really fit into this? But when you break down all of the different factors, such as the mental health impact and the sexuality and sexual health side, a lot of this is are topics that we address in our clinic. So anxiety and depression, safety, self-harm, suicidality, trauma, substance use, STIs, contraception, nutrition, sleep, all of these are things that we may see in adolescent patients. And so although we are not the ones who will be actively delivering these babies, we can have a really impactful role in a lot of these areas of these youth's health. And then the advocacy for vulnerable populations. And so the stats at the bottom of this are from our One Chance to Be a Child report. So again, showing that 1 in 5 children and youth live in food insecure households, 88% graduate within the expected time frame, and more than 1 in 10 are estimated to be in poverty that deprives them of their basic health needs. And so our role as an advocate for child health is a big part about how we can support these families. I will say too, although I couldn't find a Canadian statistic for the graduation of high school for adolescents who are pregnant, in the US, approximately 50% will graduate high school by the time they're 22. So again, that's significant impact, not only in their adolescence, but for the rest of their lives in terms of future employment and educational attainment. This is a really crucial time that we can intervene and have a big impact. The lack of schooling as well, just on a side note too, it not only affects their future income, but also deprives them of that environment where schools provide the peer support, they have caring, invested adults who are around them on a frequent basis and have that community support. So they're also being deprived of that environment that their non-pregnant peers are able to receive. So again, that focus on still keeping them connected with their school environment is so important for these youth. Again, from the One Chance to Be a Child report, that increase in concerns about money for basic necessities goes up significantly for those who are less than 20 years old. So a lot of our youth pregnancy population, and in general, parents across the board reporting unaffordable housing. And so now just a note on the vulnerable populations, and this is not an exhaustive list. There's many vulnerabilities and a lot of intersectionality of these vulnerabilities for our patients, but thinking even more so about our adolescents who are Indigenous, who are Black, non-English speaking, new to Canada, gender diverse, unhoused, those in DCS care, using substances, mental illness, and many more risk factors, just put them at increased vulnerability as well. So we really need to know about what community-based resources are available to our youth and to try to be connecting them as early as possible. In terms of the women who are Indigenous and adolescent pregnancies, there's an increased amount of adolescent pregnancies in the Indigenous population. And so we also need to be thinking about culturally safe maternity care, particularly knowing that there's a lot of hesitation in coming to the hospital given the historical context of these children being taken into the care of DCS. So thinking about that and really trying to access those local Indigenous resources that we can be providing adequate care. I know I saw in the chat some questions about that as well. And so questions about, oh my, there's lots of things, we'll address them afterwards, but the significant needs and models of care. I will say there's not a necessarily model of care for adolescents who are Indigenous in pregnancy, sort of all of those factors. That being said, there's a lot of maternal and child health resources. I know particularly here in Nova Scotia through our Mi'kmaq Friendship Centre. So that would be a resource that I would definitely reach out to if I had an Indigenous adolescent who was pregnant. And again, just the statistics as well about the disproportionate increase in Indigenous children in foster care. So, which brings us back to that point about the general lack of trust in the DCS system. And we need to be aware of this so that we're not perpetuating the racism and intergenerational trauma that has occurred with the historical pattern of these children being taken into care. Which brings me to the sort of end of our presentation when it comes to really how we can provide that youth-friendly approach to healthcare. And so I hope that by the end of this presentation, I've not only provided you with a framework to approach the complete care of these youth and their babies, but also that we've put a spotlight on the gaps that exist in our current system and how we as pediatric providers can advocate for these children and families. I do want to provide you with resources from our local community. I had initially tried to put these all into QR codes, and then I realized I would have probably 20 slides of QR codes. So I'm very happy to send these to anybody after the presentation. So there's some clinical management guidelines. So the SOGC guidelines was the biggest one for clinical care, as well as some postpartum guidelines, the Rourke Baby Record, which is for the primary care of these infants, as well as, again, for the Indigenous health resources. The perinatal services in BC had a number of online resources. Again, I know that's not hands-on care here in our province, but it did have some good online resources, again, to kind of help you direct your care for these patients. In terms of, we all know our CPS guidelines, there is a CPS guideline on meeting the needs of adolescent parents, specifically the tables on the basic healthcare needs of both the parents and the children of those parents. I thought were really helpful for sort of practical screening in clinic, as well as the positive parenting. We have many options for community programs. I put one QR code because I thought this was the most important, which is our family resource centers. There's a lot of really excellent programs happening, and they're often present in a lot of our local communities. And they get a lot of funding from the prenatal nutrition program and the community action program for children. There's also a Mi'kmaq Child and Development Center, which is associated with our local, the Mi'kmaq Friendship Center. And then many resources under housing and financial support. I want to highlight the supportive housing for young mothers. I know that's been really impactful for a lot of families locally. Again, the Mi'kmaq Native Friendship Center. MOSH has some mobile outreach support health teams, so that can be helpful for those who are chronically unhoused and may need services that aren't provided on a drop-in basis. And then the maternal education, a few to highlight here. The IWK Pregnancy Instagram has some excellent educational resources that are also very youth-friendly and in sort of a mode of social media that I think youth interact with frequently, as well as there's a number of online resources here. an excellent, yes, Leanne just shared about our Indigenous health consultant, Courtney Pennell, as well, who I think is also an excellent resource when it comes to the sort of intersectionality of the adolescent pregnancy, but also with Indigenous adolescents. And then again, more patient safety or patient education resources here, and resources for families in other languages. The CPS has some excellent translated services there. And so I'm happy that we have some time left still for discussion, as I'm really interested to hear from everyone on this Zoom call in terms of if there's any models that are happening in our community and sort of outside the walls here of the IWK. I need to express significant gratitude and thanks for the support and guidance of Dr. Tanya Wong and Dr. Celine Etches, who have been instrumental in helping me sort of as I've gone through the research of this topic, as well as our colleagues in obstetrics and gynecology, so Dr. Nancy Van Eyck, as well as their social worker, Corinne Sove, who've helped me again with understanding the obstetrical side of this issue. And that's my email there. So if anybody wants a copy of these slides, particularly those resource slides, I'm happy to send those along. And then.
Thank you, Emma. That's an excellent presentation. Folks, if you want to put your questions in the chat box, and there's some there already. And Emma, one question I think I would ask while we're waiting for people to populate it, and some people have made reference to this already. The original case that you described of the 14 or 15-year-old at the very beginning, let's say who lives in HRM, how well would that young person be served by the way we're set up now? Can we do better in terms of wraparound services, in terms of having one person who, and this was suggested in the chat box, having a professional be a public health nurse or a doula or someone who actually goes out to the home and visits and builds that trusting relationship and is that navigator, advocate, expert person that you've referenced in some of the other models. So how well would that teenager do in HRM right now based on what we have?
Yeah, so I think that when I saw that case, what really struck me is that I don't think that patient would have received any amount of adequate care from a healthcare perspective if they hadn't had practitioners who were really advocating for them. So going through those steps, when I mentioned all of the barriers that they had encountered, the only reason they were able to even get past the door screeners or get into the hospital to go to some of those appointments or know that they had missed appointments was because they had someone who was actively advocating for them, very much outside of what they sort of were expected to do in clinic. So I also think that they benefited from having the access to a drop-in clinic, which I know is very difficult to provide, but for patients who are unhoused, I think that that's one of the keys, and is mentioned in the CPS guidelines on harm reduction and street involved youth, to have those options for patients. So I think a lot of things came aligned to even allow that patient to make it into the IWK for care. I do think, though, we are still limited in what we can provide in our clinic. These patients exist not in the walls of the IWK, but outside in the community. So I also agree that having those community resources involved and being able to meet the patient sort of in home visits or other experiences is also integral to the care. But I think the biggest thing was just the lack of coordination of that care. So having, as you mentioned, like a point person or having a coordinated effort so that we're not losing a lot of these patients through the gaps in our system.
Great. And Chris, if you want to read Chris's questions, Emma,
Oh, yes.
As care providers, how have experiences been for our advocacy being factored into DCS decisions? I think as junior trainees, we can feel powerless and or weary when reporting as a result of all the systemic barriers that you've pointed out. In addition to all the local efforts discussed, how are we advocating for youth health as the province moves into discussing funding for healthcare at the federal level? Curious to know if anyone is doing this work right now. Thank you for a great talk. I'll just add quickly, Chris, and then I'll turn it back to Emma, that we do have some youth health centers in high schools across the province. There's quite different models. The Cape Breton model has a physician, either a pediatrician or family doc, visiting once a week, along with a steady nurse there all the time. I know we reduced our teen pregnancy rates by 50% after we put that model in. On the mainland, we don't have that model yet. And about 25,000 children under the age of 16 and adolescents under the age of 16 do not have primary care providers, which adds, and probably a lot of those folks are disadvantaged, I suspect, but to add to Emma's point. But Emma, do you want to tackle that one in terms of the DCS decisions? Go ahead.
Yeah, I can. So thank you so much, Chris, for that question. I think there's a lot of frustration at times in working with sort of DCS and the decisions around taking some of these children into care. I know, again, I'm still new in my residency and some of these experiences, but even I know I've noticed some situations, for example, on the NICU, where even in a situation where they were provided significant support by our NICU social worker and by our healthcare team, the healthcare providers were still in the dark in terms of whether that parent was able to take their baby with them at the end of their NICU stay, and really didn't know until the last day that they were being discharged. So I think that there is still a role for us advocating and trying to seek that information, and also with the recognition that sometimes there are those really like we're not always looped in on those conversations. Trying to have these youth set up with support early, I think, is really instrumental, because I think again, in the small amount of cases I've seen, the times where it's been successful is when they've had that support. So for example, one of the families that I worked with in NICU, and we were able to provide them with the education so that DCS was potentially a bit more convinced that this youth could take care of their baby when they went home. And so it really breaks my heart thinking of if they don't have that education and they're not given a fair shot to even show that they can develop those skills, that then I find sometimes it's a bit too late for our role. So I think that early involvement is really key, because I totally agree that sometimes we can feel a bit powerless in those situations. And then in terms of the local efforts, as Dr. Link said, there are some which vary by community. I know, again, Dr. Tanya Wong and I've had many conversations about the potential for how we can provide these services. I don't think there's any necessary initiatives currently about obtaining that funding, but I think there is a lot of interest, again, with some of my mentors in this area. So would be very happy to continue this conversation.
And Emma, Dr. Beth Cummings wondered to know anything being done to address the issue of ultrasound booking notifications for adolescents who don't necessarily have phones or need someone else to be notified. And Dr. Tanya Wong has said she's looked at this with radiology. There aren't any clear solutions to that one right now. We may have to be more vigilant in setting up appointment times ourselves in Meditech and communicating back to the social worker or youth worker.
Yeah, definitely. I think some of that, and it's particularly, I know I mentioned that some of the access to care and not having a lot of drop-in appointments. One of the other suggestions when it comes to some of the harm reduction or strategies for street-involved youth is to try to get that information in the moment when you're seeing them. So if there's any way that we're able to add a clinic appointment, notify them of when the ultrasound is, or get their permission that we can contact radiology and then tell them about their appointment time, I think all of those are solutions right now, but no, there's no systemic sort of solution currently with radiology about that.
Mm-hmm. And then if there was ever an area where an early investment would save a lot of heartache and future costs to everybody, including the child and the parent and society in general, this would be the time, I suspect. Yeah.
Definitely. And I think it just really struck me too, as I went through just the context of the lack of research and lack of sort of early intervention for this perinatal risk factor compared to some of the other excellent supports that we have for other perinatal risk factors, such as prematurity and other things that we are researching in terms of the medical lens. So I just think really bringing to light that those social risk factors can have a very similar impact on outcomes for the neonates.
Great. Any other questions for Emma, folks? All right. I think, Emma, that the thing that gives me great hope is that, to have young people like yourself and Dr. Wong and Dr. Etches and Dr. Van Eck and Corrine and others, we get a critical mass of people who are interested in this and looking at system change. That's what's going to make a difference. And so thank you for doing this. And I guess I would just say, folks, this has been recorded and will be on our YouTube site. So if you want to go back and reference it again, you can. And hopefully, Emma, we'll have you back here in a few years when you're on staff giving an update on this as well. That'd be great.
Thank you very much. And again, happy to send these slides to anybody. And thank you for all the questions. I appreciate it.
All right. Have a lovely Wednesday, everybody. Thanks for attending today.